Hi guys, welcome to another lecture, and today we will discuss basics about pediatric seizures. So before beginning, I would like to request you to like, share and subscribe to this channel if you haven't already. And if you do not know, I have an app, and on that app I have multiple lectures for everyone. So on the Simply Pediatrics app, you can find the link in the description. It is available for Android, iOS both, and courses, image-based courses for next NEET, PG, and INE set aspirants, and for resident and UG masterclass are also available. If you haven't already downloaded the app, please download it. And if you haven't followed me on Instagram, please follow me on Instagram. I post one image-based question every day. Also on the app right now, we are currently running huge discounts. So please make sure you avail them. So pediatric seizures, very important, pediatric seizures. So let's see most common. So most common seizures in neonate is subtle seizures. Okay. Most common in children is febrile seizures. Okay. Then most common, most common benign epilepsy. Most common benign epilepsy. Okay, not seizures. Most common epilepsy or benign epilepsy in pediatric population, it is a Rolandic epilepsy. And most common cause of death with epilepsy is SUDEP, sudden unexpected death in epilepsy. So that is SUDEP. So this is the most commons, and I hope you have seen them. But now the important part is, first is febrile seizures. Febrile seizures are autosomal dominant conditions where it occurs between the age of 6 months and 60 months or 5 years of age, and the temperature is a temperature more than 100.4 degrees Celsius. When it goes, the child suffers from epilepsy. Now, this epilepsy is of GTCS type. Most commonly, it is of GTCS type, and it is associated with SCN1A mutation, sodium channel mutation, SCN1A mutation. Now, there are two types of febrile seizure. So, one is simple febrile seizure, and second is complex febrile seizure. So, what is a simple febrile seizure? It is GTCS in nature, less than 15 minutes of duration, and there is no recurrence within 24 hours. Okay, one episode of epilepsy within 24 hours. While complex seizure is either focal, or it lasts more than for 15 minutes, or it recurs within 24 hours. So that is the complex febrile seizure. So that is the first thing. The second epilepsy that we see in pediatric population is the subtle seizures and benign neonatal seizures. So we'll see there is a classification of pediatric epilepsy, and that epilepsy is Volpe's epilepsy. The classification is known as Volpe's classification. First is subtle seizures, where the neonate has cycling or swimming motion. The child has cycling or swimming motion. Then the other type of seizures are the tonic seizures. Then there are clonic seizures, and there are myoclonic seizures. Okay, myoclonic seizures are jerk-like movement, sudden jerk-like movement is there, and it is also associated with poor prognosis. Myoclonic seizures are associated with very poor prognosis. Okay, the third is absence seizure. Okay, we'll just see the drug of choice. So over here, the drug of choice in newborn is injection phenobarbital. Phenobarbital is the drug of choice for a newborn, while in febrile seizures, the treatment of choice is to reduce fever and intranasal midazolam. Intrarectal diazepam is not used. Intranasal midazolam is now available, so we prefer them. Absence seizures, very important, absence seizures. So absence seizures, we have 3 hertz spike and wave pattern, or spike and dome pattern, and spike and wave pattern. And here there are episodes where the child looks like the child is daydreaming. There is no loss of consciousness in typical, absence seizure. The child does not lose consciousness, and the tone is also not lost. So no loss of tone. Okay, and there is no post-ictal confusion. No post-ictal confusion. So that is what absence seizure is. Treatment of choice for absence seizure is the ethosuximide. It is a T-type calcium channel blocker. T-type calcium channel blocker, and it is more preferred compared to valproate. Initially, it was not available in India. Now it is available. So ethosuximide is the drug of choice, not valproate. That is the absence seizure. There are also atypical absence seizure where there is the triad of atypical absence seizure. The triad of atypical absence seizure is 2.5 or it is less than 3 hertz. Less than 3 hertz. The frequency of the epilepsy or the EEG is less than 3 hertz. Then there is decreased IQ and there is loss of consciousness. So this is the triad of atypical absence seizure, and it is associated with worse prognosis later in life. The fourth epilepsy that I wanted to tell is juvenile myoclonic epilepsy. Now, in these patients, juvenile myoclonic epilepsy, it is 4 to 6 hertz polyspike pattern, and there is exacerbation of seizures after a overnight. The child has not slept overnight, and child suddenly develops seizures early in the morning, and there is a 4 to 6 hertz polyspike pattern which is stimulated on photic or phonic stimulation. The drug of choice is valproate. Majority of these patients get converted into either GTCS or they get converted into the other epilepsy. That is why you have to remember this. The fifth epilepsy that I wanted to remember is Ohtahara syndrome. Ohtahara syndrome. Ohtahara syndrome is early infantile epileptic encephalopathy. See, this is very important. This is early infantile epileptic encephalopathy. What happens is that seizure will lead to encephalopathy. Seizure will lead to encephalopathy, hypoxic damage to the brain. It is neonatal in onset and there is burst suppression pattern. If any EEG in a newborn or a child shows burst suppression pattern, it is associated with extremely poor prognosis. And that is why burst suppression pattern is associated on the awake patient, and that is known as Ohtahara syndrome. Ohtahara syndrome has extremely poor, the prognosis, but the treatment of choice we prefer valproate. Then the next one is West syndrome. West syndrome is the triad of West syndrome is triad of hips arrhythmia. Triad of hips arrhythmia, infantile spasm, and mental retardation. This is the triad of West syndrome, and in that it is also known as Salam seizure. Salam seizure. There is, see, the child tightens like this. The child is ophistotonic. It looks like the child is ophistotonic. It assumes the posture of ophistotonus. It may be associated with congenital ARX mutation, and if it is associated with ARX mutation, then the child may have ambiguous genitalia. Okay, so that is important. There are multiple. See, the history will be that the child is 4 to 8 months of age, and child has 100 seizures in one day. That is the history. That is you hear with West syndrome, 100 seizures in one day. So that is how the West syndrome is. It might be flexure, extensor, or mixed. And the treatment of choice, the drug of choice is ACTH. In India, ACTH is very expensive and it is not preferable. That is why we can prefer prednisolone. Prednisolone has equal efficacy compared to ACTH, and high dose prednisolone may be used for the treatment, and vigabatrin, as you know, is the drug of choice for West syndrome associated with tuberous sclerosis. Okay, so that is the vigabatrin that is used. So these three drugs are used in patients of West syndrome. Now, seventh is Dravid syndrome. Dravid syndrome. What is Dravid syndrome? In patients of Dravid syndrome, what happens is that they have a typical history. They begin as atypical febrile seizures. They begin as atypical febrile seizures, and later on, they convert into multiple seizure types. They get converted into multiple seizure types. Okay, they might get converted, like initially they are atypical febrile seizures, but later on afebrile seizure starts coming, and then there is a developmental delay, gross developmental delay. The child is mentally retarded, and in that you have to understand that seizures are fever responsive. Like, they after later on they might occur in even afebrile patient, but also they have some exacerbation with fever. Now, the most important thing with Dravid syndrome is, the patient worsens. In Dravid syndrome, the patient worsens on sodium channel blocker. Sodium channel blocker due to the mutation in SCN1A region, the same region of febrile seizures. But here it is more extensive damage. That is why when you give phenytoin, when you give carbamazepine, the patient will deteriorate like anything. So first you have to give drug of choice is valproate, but if the patient does not improve on valproate, give clobazam or benzodiazepine. Don't give phenytoin or carbamazepine, and that is very, very important. Also, there are alternating side seizures. If they have a history of alternating sides, like I had a focal seizure on the right side, tomorrow I have on the left side. And ketogenic diet has a fantastic role in patients who have Dravid syndrome. Ketogenic diet is used for refractory seizures of Dravid syndrome. That is why you have to be very, very careful. The Dravid syndrome is also known as severe myoclonic epilepsy of infancy. Okay. Then there are two syndromes. There is, occipital epilepsy. Occipital epilepsy. So there are two types of occipital epilepsy. One is early and other is late onset. So early and late. Now, early onset is also known as early onset occipital epilepsy is also known as Panayopoulos syndrome. Okay, and late epilepsy is called as Gustot epilepsy. Not Lennox-Gastaut, it is just Gustot epilepsy, and that is very important. It is not a Lennox-Gastaut epilepsy, it is just Gustot epilepsy, and both are different. Now, in this early epilepsy, there is a hallmark that seizure occurs with vomiting. So, seizure occurs with vomiting with autonomic involvement, like sweating. Autonomic involvement. Drug of choice, again, valproate. No, sorry, the drug of choice is benzodiazepine over here, intermittent benzodiazepine. Now, in late occipital epilepsy, there are visual hallucinations with photosensitivity. So that is what you see with late occipital epilepsy. Then the last some are, one is Douce syndrome. Douce syndrome is myoclonus with atonia. Atonia with myoclonus. It is myoclonic atonic epilepsy. So Douce syndrome is myoclonus plus atonia, and treatment of choice valproate. If you do not know what is the treatment of choice for any epilepsy, write valproate. You will probably be right. Then there is a benign Rolandic epilepsy. Rolandic epilepsy. Now, Rolandic epilepsy has a few features. So what happens is, it is a childhood epilepsy, occurs at 4 to 11 years and resolves by 16 years. 16 years, 100% resolution is there. 100% resolution is there. The patient grows out of this epilepsy. And what are the findings? There is paresthesia of mouth. Paresthesia of mouth and tongue. With gagging of the tongue, gagging and drooling. So this feature is there, and if you do EEG, you have centrotemporal spikes on ECG. If you have a centrotemporal spikes, this has the best prognosis, and it is a benign Rolandic epilepsy. The drug of choice here, the benign Rolandic epilepsy, the drug of choice preferred is carbamazepine or valproate. Second, the next is Landau-Kleffner. Landau-Kleffner is aphasia, acquired aphasia. acquired aphasia with epilepsy. What is there that the patient has epilepsy, and due to epilepsy, patient neuroregresses to forget how to speak, and the patient goes in aphasia. So that is why the patient has aphasia with epilepsy. There are also Lafora body disease and all that, but we will not get into it. Last one is Lennox-Gastaut syndrome. The triad of Lennox-Gastaut syndrome is multiple seizure types, cognitive impairment, and slow spike wave pattern on EEG. So what happens is the patient has multiple seizure type and patient later goes in encephalopathy, and that is why this is one of the worst epilepsy. Treatment is valproate, drug of choice is valproate, but it might require multi-drug therapy because the disease is very severe. That's all for today, guys. I hope you like the video. If you like the video, please comment down below, like, share, and subscribe. I'll see you in the next one.